These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology assessment. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started today. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat feature for communicating issues with technology or communication access issues. Please refrain using chat to ask questions or make comments. Please note that closed captioning is also available, and that is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at telehealthresourcecenter.org. With that, I will pass it over to Lloyd Sermons, Director of the Southeastern Telehealth Resource Center.
Yeah, thank you, Aria. It's an honor to have joining us today and presenting Mr. Peter Gardella. Peter works with MUSC and the Center of Excellence there and the Telehealth Department, and they have been a partner of ours for a number of years. He's the Director of Telehealth Operations and Nursing at the Medical University of South Carolina, their Center for Telehealth, which is one of the HRSA designated Centers of Excellence. He's very accomplished, so we were joking a little bit earlier. I didn't want to cut him short on all of his accomplishments. He completed his nursing school at James Madison University, and then he also completed a master's in business administration and healthcare management from Liberty University. Began his healthcare career as an EMT paramedic before completing nursing school and working as an emergency department RN. After earning his MBA, he was accepted to MUSC's Administrative Fellowship Program, where he worked closely with the Chief Quality Officer, Chief Nursing Officer, and then the Chief Operating Officer. Once he completed his fellowship in 2017, he worked as an assistant nurse manager for the MUSC Adult Emergency Department Level 1 Trauma Center. And then later became the nurse manager of the MUSC Pediatric Emergency Level 1 Trauma Center and the Neonatal Pediatric Critical Care Flight Team before moving over to MUSC's Center of Telehealth as the Director of Operations and Nursing in 2021. So, Peter, it's an honor to have you with us today, sharing with us, and I'm going to just turn the floor over to you.
Sounds great. Thank you. Thanks for having me. As we go through this, a lot of the work, a lot of the services that we'll see is the result of an amazing team, lots of people, physicians, and our team here in the Center for Telehealth as well. And so hopefully we'll capture some of that work as we move through. So our goal is that in the short time that we have is to talk a little bit about what type of telehealth services are deployed in the inpatient setting, specifically in the MUSC use case, Medical University of South Carolina. But this is not always unique to our setting. In many cases, you'll recognize services that either yourselves deploy or have seen deployed by other healthcare facilities. We'll try to touch a little bit of how we deploy these services, a little bit of the operations behind it, and then some of the why we choose to develop and implement these inpatient telehealth services, because the varying use cases are what drive them. The different reasons for supporting these strategic areas are why we support these services. And then understanding that as we talk, telehealth is not meant to replace in-person care, but to strengthen it. And that is especially true in the inpatient setting. And also it underpins the services that have different use cases and how we deploy them. You'll see a couple icons as we go. I may not be able to touch on everything, but I try to summarize how we do it, and that includes some of the technology. You may recognize some names and some platforms, how we maintain it. So a little bit about our operational support and structure, and then also how we sustain it, some of the objective criteria we look for deploying and achieving quality outcomes, return on investment, because there's different value cases as we move through. Important for setting the stage, I think, for these inpatient services, especially in the context of critical needs. It's important to understand a little bit of the background of our state, South Carolina, and our health needs assessment that was recently published through 2023. Some related findings that came from this, and the links are there for you all to see the South Carolina example. Perhaps no surprise, access to healthcare is the #1 issue. What I highlighted was something that was a surprise to me. Health system mergers are affecting physical localities and especially rural areas. That's going to come up a lot. And so as MUSC and a lot of your facilities perhaps are expanding and merging with other health systems, that is, even if it's meant to improve access, is showing up in our areas as a possible inhibitor of access. And so something that I keep in mind is something that we're hoping to fix. 10% of South Carolina households have no internet access. We do have a robust broadband and team in South Carolina that has some funding and some action plans over the next several years to improve that. And some barriers to improving the access in South Carolina to healthcare is not just the availability of health insurance, but also the ongoing healthcare workforce shortages and the lack of healthcare facilities. And so another reason that telehealth for inpatient services has become high demand. Rural areas have a higher overall death rate than urban areas, not much of a surprise. And then ultimately 27% South Carolinians live in rural areas. In addition to that context, a little bit about us. Medical University of South Carolina is the university hospitals in Charleston, South Carolina. We are an academic medical center serving all 46 counties within the state. We do have 16 hospitals, 12 of which are tertiary care centers, and 2,700 licensed beds. I might refer to MUSC hospitals as internal hospitals if I accidentally say external hospitals, because we do deploy telehealth services to non-MUSC hospitals as well. Specifically, our Center for Telehealth is one of 2 national telehealth centers of excellence, University of Mississippi being the other, who is charged with developing and deploying telehealth services to rural areas and then studying the impact and researching it. Not all of them are success stories, and I'll have a link at the end of this for you all to see the COE website to learn from UMMC and ourselves. We do have a South Carolina Telehealth Alliance headquartered at MUSC with over 700 supported sites across the state. And then specifically our center, we have over 85 clinical care team members supported to drive our services, not just inpatient. And then most providers at MUSC participate in telehealth, but we have over 45 funded providers with various dedicated time and paid for to complete these services. Our history might not look different from other areas, but has gone back to early 2000s, the early years primarily being some of those inpatient use cases, telestroke, telepsych, tele-ICU. In 2013, state of South Carolina government decided to invest in expanding healthcare access through telemedicine. And that's when the MUSC Center for Telehealth was born. And a year later, the South Carolina Telehealth Alliance was founded, headquartered at MUSC, and founded to steward the investment that South Carolina has made. And so we do have some level of state funding supporting these services. We talked about the Center of Excellence, designated by Health Resources and Services Administration, established in 2017. And then, like most people in 2020, saw a massive expansion of telehealth adoption and utilization. For a while, that's where our timeline ended. And so trying to update that to move into the next phase of healthcare redesign. And our trends, as I've put up there, are not indifferent than or different from others, but we do see them leveling off and possibly climbing. And we think that's because we're finding the right uses for telehealth in the right areas and deploying them. So specifically moving into inpatient telehealth services, I hope to show a little bit about our organizational structure to show how these services are deployed. And then we have two main buckets of inpatient services: consultative type services, and then rounding and monitoring. Our structure from a high level on the inpatient side, acute service side, we have an executive medical director, many of whom you all know, Dr. Jimmy McGilligan, our administrator, Emily Warr. Under them is myself, and then we have an acute services nurse manager, Shay McLeod, who oversees these services and their deployment. We have an excellent team that involves tele-registration, clinical support nurses, and then a 4-person RN outreach coordinator team that does a bulk of the background work and keep these services moving and maturing. Recently, we have 2 on-site telepresenters to look at the impact of having on-site support for these services. And then we have cross-functional support, including our telehealth technology team and then a business development team to help us with some of those business functions and technology functions. Day to day, we're looking at supporting physician scheduling, contracting, same at the hospital. We're looking at the same things many people are in in-person services like note routing, professional billing. Longer term and sort of in the background is continuing quality monitoring and KPI tracking and having regular reviews and touch points with internal and external hospital leadership so that they see the outcomes that are being delivered and the return on investment. The quality monitoring, I do want to say, is not passive. It's very active with ongoing data gathering and tracking, and it's not all the numbers. Sometimes our RN outreach coordinators are calling patients who have received thrombolytics after having a stroke at 90 days to get their modified Rankin score. And so that was one example that happened recently. And so when our outreach coordinators had called a patient who had had a stroke and had received thrombolytics, called it the 90-day mark, and the patient picked up. And the patient had a bunch of wind in the background. And our outreach coordinator said, where are you exactly? It turned out this patient was on a cruise 3 months after receiving thrombolytic therapy to save their life, having a stroke. And so improved quality of life, I think so. This is a feel-good story that we're certainly proud of and happy to see. Again, not a story unlike ones that you all have or are able to share as well. But for us, seeing where it came from and how the telestroke program grew, I think is what is fun to see. The telestroke program, specifically starting in 2008, you can see, and then growing to where it is today in 2024, delivering services across the state and continuing to change as we are able to help spread these services even further. Moving from there, it's not just about spreading across the state and utilization, but starting to mature and looking at our quality impact. And so over the years, 75% of our partners are now certified by Joint Commission or DMB in primary stroke center and stroke certifications as supported by telestroke. 100% of citizens over the years are now within at least an hour of expert stroke care, many times within 30 minutes, making it possible for patients to receive the targets of thrombolytic therapy within 60 minutes and 30 minutes, which has been a huge accomplishment in South Carolina, at least. Most recent quarter is median door-to-needle time, 56 minutes as a main outcome of treating stroke patients, and that is statewide. And despite growing from the 4 hospitals to the ones you see today, still an upward trajectory in door-to-needle improvement across the state. Something we're really excited to continue to mature in and develop is a statewide collaboration of improving door-to-needle times. And so having the stroke coordinators and the leaders from those various hospitals come together to talk about and share best practices so that we can work together to continue to drive statewide improvements. Moving on from stroke, that may have been what helped us kick it off, but we have certainly expanded and continued to develop and deploy additional services. We also offer a consultative model and services in neurology, psychiatry. We have tele-EEG as well, palliative care and infectious disease. And then some smaller services that we're continuing to grow, like cardiology, tele-EMS, where patients can get in contact with our stroke neurologist from within the ambulance. And then some other services, niche use cases like PEDS critical care support and ED provider, virtual provider and triage to support patients waiting in the waiting room and left without being seen times. In general, this is a synchronous video that occurs, and our current vendors are Teladoc and through Andor. We do have MUSC providers providing this care, and the acute services are 24/7, operationally supported by the Center for Telehealth. And of course, the goal here, our primary goal, is to improve access to specialists within the local hospitals, both in their EDs and in their inpatient settings. Reducing transfers, which reduce costs of care, coverage for those areas to keep the care local, and then having an impact on their quality measures and hospital outcome measures as well. The volumes for some of the bigger services that we've been providing and supporting are continuing to grow and mature, and we're looking forward to expanding them further. Broken down even further, our consultative services can be urgent, emergent, like stroke, but also acute neurology. These are available 24/7, 365, always having a provider available to respond with a current response time average of 6 minutes across the state for each of these acute and urgent needs. The general process and workflow is that a site will have a patient and request this consult through our admit transfer center, who then pages it out to our on-call provider based on the schedule and call coverage that we help provide. Then the provider joins the video with the patient at the distant site using a cart very similar to the one you see there, in many cases that same one. What you don't see is on the other side of that screen is another screen. And so the direction we're looking at is for the clinical teams to be able to see and document as the patient is cared for. On the back of that, the patient will see the provider and the camera and be able to act as though they're speaking with the provider there in person. We do also have what we call scheduled consults. It's in quotes because the site will call us for consultation requests that are not urgent, emergent. And so similar to sort of an outpatient type model, we will schedule these patients on paper for a date and time that works with both the site and our providers, and then have that patient be seen. This happens now through our tele-registration team that we've recently centralized within our own team inside telehealth. Providers are able to view their schedules in Epic and have that continuity that way. Some efficiency wins that we'll like to share is we're constantly trying to improve on what we're doing. We have not yet figured it all out. The patient list is moving from a scheduled type model to more of a list type model. And so continuing to remove some of that waste, some of those open slots that aren't filled in a typical outpatient basis, and move to a list where providers can move from patient to patient. Because they're moving patient to patient, hospital to hospital, that's where our clinical team will come in and schedulers to support patient readiness at each of those sites to tee those patients up so that the providers, are able to move efficiently through their list. In some cases, telepresenters are on site to support the logistics of moving the cart around and have been shown to reduce late cancellations, meaning the patient was supposed to be seen at a certain time and for various reasons was not able to be seen. Which prevents a time where we can see another patient. So major wins in this area. Something we're continuing to focus on is communication and sharing of information via the EMRs. And so we're looking into leveraging health information exchanges through EMRs to be able to have immediate access to patient records and consultation note transfers. Looking at some of the telehealth rounding and monitoring service, they have a slightly different structure, still synchronous video at times when rounding or monitoring the patient directly, but also infusing some phone calls, some chart review to be able to essentially keep track of the patient and offer insights throughout their inpatient stay. Because this is more of a rounding or monitoring type model, it definitely leverages and requires the on-site support of both clinical teams, but also providers. And so in many of these cases, our team will work with a advanced practice provider to round on these patients daily, relying on the assessments of that advanced practice provider. But in some cases, that provider is able to leverage peripheral devices like a Bluetooth stethoscope. So our attendings back here in Charleston are able to hear what the APP is hearing and support them. Some services that we've deployed in this area include very recently inpatient geriatric psychiatry unit, teleneonatology, telehospitalist services, tele-ICU, which has been around for a long time for us in partnership with Acuity, and then also recently and expanding virtual nursing in partnership with Virtue Ally, and that includes their virtual sitting program as well. Some big wins right out of the gate, showing early promises, still lots to learn and mature on, but being able to support a hospital, one of our local hospitals, with inpatient geriatric psychiatry attending coverage, help them reduce $800,000 in locum coverage, and I've already seen a 75% reduction in length of stay over the locum coverage. For teleneonatology, as we continue to mature and gather robust data, an early win at a hospital, one of our partner hospitals in the first year, was that 77 moms were able to deliver close to home because of the service that enabled them to stay in their area, go to the hospital that they know, and be close by. And then additionally, telehospitalist coverage is, they've seen in the last, our fiscal year, June to July, over 5,000 patients census in 1 year, helping patients stay close to home, stay admitted in their local hospitals. Our tele-ICU program is in partnership with Acuity Health. They've been excellent partners. This is a very robust ICU level monitoring. In some ways, virtual nursing, before virtual nursing was a thing, it does involve 24/7 continuous monitoring by the Acuity staff. It does involve synchronous video at times to support the bedside. And then it does what tele-ICU provides and what MUSC contributes to are intensivists to support the on-site providers, APPs, critical care nurses, and respiratory therapists monitoring patients across over 110 locations across the globe for Acuity. Specifically in South Carolina, we are located in 8 ICUs. With, in the last year, 121 lives saved as compared to Apache predicted mortality, monitoring over 14,000 patients in 1 year. Major improvements that come out of this and services that come out of tele-ICU is improved length of stay, adherence with best practices, reduced readmissions, and then obviously hoping to make an impact on sepsis and mortality in many cases do. This is in partnership with Acuity, and we've seen almost 78,000 patients in the tele-ICU in South Carolina sites alone since 2015. We do also operate one of Acuity's 11 operational hubs, and that is a picture of the hub that's just a few doors down from my office, where we offer 2 ICU nurses and 4 intensivists, including a medical director, to provide coverage and support in partnership with Acuity Health. Our focus is the South Carolina hospitals to have care be delivered locally in our state, but we also contribute to the needs of Acuity and help see patients in ICUs across the country. In partnership with Acuity, in partnership with our sites, we also offer ICU Innovations, which is meant to be an interdisciplinary team that will travel and take the outcome measures, the quality improvements, look for areas of opportunity, whether in the outcomes or whether verbalized by the local teams about questions or areas of education that they like to see. And our intensivists and our nurses will meet with them and do presentations, some webinars, some in person. And the intent is to not only build relationships, but also improve competency and comfortability with ICU patients in areas that are covered with an ICU provider, tele-ICU provider. Acuity has a robust, sophisticated quantitative reporting and quality tracking, and this is shared in executive reviews with each site quarterly. Coming up very recently with a lot of popularity, with not much surprise as to why, with the increasing nursing shortages, burnouts, and need for coverage, virtual nursing has certainly become popular. In partnership with Virtue Ally, who operationally helps deliver this service, this is a mixture, like ICU, of synchronous video, chart review, and sometimes phone support. This is 24/7 with a virtual RN. Looking to improve the areas of nursing workforce economics, like reducing overtime, decreasing overtime expenses, incentive pays, and decreasing the need for travelers, as well as reducing turnover. Also heavily focused on nursing core measures and improving best practice with hospital-acquired conditions, ultimately improving patient throughput, and hopefully increasing length of stay, or decreasing, excuse me, length of stay. So far to date, which has been less than a year, over 6,200 patients have been served in 11 hospitals in South Carolina. With data tracking, we've determined 113 days worth of time has been given back to bedside nurses, thanks to the support of the virtual nurse, and also performed through almost 9,000 sessions being conducted with our partner sites. Interestingly, though, a lot of the effort from virtual nursing is done through chart review and asynchronous review, and only 22% of the interactions with virtual nursing and the patients and the staff at external hospitals and internal hospitals involve or require video. They look in areas to support admissions, and so a new patient is admitted, and the virtual nurse, either in the ED or on the unit, is able to help check that patient in, removing a significant burden from inpatient teams who are trying to perform the intakes of new admitted patients. Supporting discharge process, including education, care planning, and like I said, doing a lot of quality surveillance to reduce hospital-acquired conditions and looking to improve documentation compliance overall to improve patient safety. Some early data, because this is also a moving target, would like to show some of the data we found. One hospital's experience right off the bat in the admission area of the HCAHPS, highest scores achieved in 4 years, also 9-point increase from the year prior on the areas of admission, and contributed by the virtual nurse. Looking at the time-based metrics of the time given back to the nurse, and being able to calculate things like an 11.2% reduction in bedside nurse time in the EMR, comes by leveraging our EMR's Epic's nursing efficiency and assessment tool, where we can dive in deep and see where the bedside nurses have been in Epic, and how long they've been spending there, and being able to measure the difference as we see the virtual nursing time in the record increase. We're hopefully able to see that the bedside nurse, at least in the areas where we're supporting, that time go down, and they're able to spend that time with patients in other ways and across the units. Also, a 37.5% improvement so far in discharge timeliness in some hospitals' experiences. And then our focus over this next year is continuing to improve reducing hospital-acquired conditions and driving that connection between the virtual nurse support and improvement in these areas. And that's outlined in the area of quality surveillance. You can see is one of the largest areas of service units, as we're calling them, that the virtual nurse is doing, followed closely by education, and then admission support and care planning. That cart is a cart of the tool that is used, wheeled to the bedside, where the virtual nurse is able to speak with the patient. And we did opt for rolling carts instead of fixed room equipment for various reasons, cost being primary, but also, as we're learning, 22% of these assessments require video, and so trying to balance out the need versus the cost. Finally, closer to home. And so these are the services we're delivering and how we're delivering them. But there's various ways that this delivers care, maintains the care closer to home. It has to be sustainable. It has to be safe. And so some of the use cases we've seen in these areas. One of them is in disasters. This has been something that we've, in South Carolina, and in many cases, other areas nearby, have experienced recently. And so in this case, Hurricane Helene had an unexpected impact on the upstate in Charleston. We all know the impact it's having, had and continuing to have on areas like Asheville and Florida and Georgia areas as well. In one of our partner hospitals, though, that we have part-time contracted psychiatry support for, we were able to get in touch with that site and that hospital, who told us that one of their stroke neurologists could not make it to the hospital because of the storm. And without missing a beat, we were able to say, that's fine, tell them to stay home, we've got it. And communicating with the ED teams and the hospital teams to immediately flip to telestroke coverage, for which we did receive several telestroke consultations, able to keep those patients safe during that time. Reduce patients' expenses is very important in being able to provide these services. We want it to be able to show that patients are staying close to home and that this has an impact. This is published in 2021 by our team, members of our team, physicians and support staff at MUSC, but still true and still data that we see today, that as over the years, as we have expanded services and TPA has been recommended for patients presenting to local hospitals with stroke, not only have those transfers gone down, but especially combining inpatient services like telestroke with teleneurology, being able to keep those patients in the local hospital and continue to care for them through local and virtual specialty care. We saw that the hospital transfers went down despite the number of TPA recommendations and administrations going up, reducing the cost on average of almost $5,000 per patient, which is a safety benefit as well as a cost savings for the patient. In addition to that, there is an ROI in that case for the hospital as well. And so they are able to, in some cases, look at typical DRG patients, DRGs for maintaining and admitting telestroke patients to the inpatient units. And so that has an ROI based on what they are paying for the coverage. And some of these use cases I've put here, and these are snapshots of reviews that we share with our hospitals in South Carolina. Hospital 2, almost $1 million in return on investment, and very high return on investment for the other hospitals as well, based on their numbers and local DRG payments. We've started to track patients retained locally. That is a success metric for us. Our goal is to keep the patients local and not to provide coverage in a way that helps them transfer to the hub, if you will, in downtown Charleston. And so you can see high 90s, 96, 97% of their consulted patients that receive a teleconsultation stay locally in that hospital, which compared to research and things like DRG payments, can also help the hospital have savings and return on investment in other areas than stroke, like palliative care as well. And it's also about quality. And so our biannual reports that we try to share with all of our hospital partners across the state is meant to bring transparency, not just to the utilization and the return, but also on the quality and how we're looking for opportunities to improve as we support them, but also opportunities to partner with them to continue to improve other areas as well. Our goal is to help drive those outcomes, and we do that through tracking the data and presenting it in partnership with our sites. So ultimately, telehealth is meant to be a support mechanism. It's not meant to replace in-person care. It's meant to strengthen it. It's meant to find areas of need in unique areas across the state, rural and urban, and solve for that need. And so strategic virtual support for those hospitals is really what's needed and what helps keep those patients close to home. Two resources that I'm happy to share if you aren't able to click here or see it here, but our South Carolina Telehealth Association has a website, and you're able to comb through it, and I invite you to see the resource guide, service overviews that they've produced. And then also the Telehealth Center of Excellence website in partnership with the University of Mississippi Medical Center. You'll see some of the work and some of the literature and research published and shared throughout our work. Like I said, not all of it successful, lots of learning opportunities, but that's exactly what we hope to study and be able to continue to share. Happy to take any questions.
Yeah, thank you for that, Peter. And so I think if you have questions, you are more than welcome to post those now in the chat, and we'll monitor that and try to get those answered best as possible. I'm not seeing anything in the chat. Aria, I don't know if you're seeing anything.
Nope, I don't see any questions. I did get a couple of questions that I already answered in the Q&A. Just as a reminder, the webinar recording and slides will be posted to the consortium website at telehealthresourcecenter.org within 24 hours.
Great. Any questions for Peter before we allow Aria to close things out? Okay, Aria, I think it's safe to say if you want to kind of take the floor and hold on, we do have, so it's just a comment coming. I'd say go ahead, Aria, with that. If it pops up, I'll let you know.
All right, yeah. Just a reminder that our next webinar will be held on November 14th. That has been rescheduled from our regular third Thursday schedule due to the holidays. It will be on federal cybersecurity resources for telehealth, and it will be hosted by the Northwest Regional Telehealth Resource Center. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to the Southeastern Telehealth Resource Center for hosting today's webinar and to Peter for his presentation. Thank you and have a great day, everyone.
Bye, guys.